With this, we come to end this session. We'll now proceed to the next session, which is Industry Symposium by Getz Pharma. Before I invite the speaker, I'll first invite our chairpersons to chair this session. The first chairperson is Professor Javed Akram, who is Professor of Medicine and President of Pakistan Society of Internal Medicine. He's also former Health Minister of Punjab. Sir, please join us on stage. Our second chairperson is Professor Abdul Jabbar. He is Professor of Medicine and Consultant Endocrinologist at UAE. He is the founder and former President of Pakistan Endocrine Society. I'll invite our speaker, Professor Aziz Rehman. He is Professor of Medicine at Rashid Latif Medical College. He is Senior Vice President of Pakistan Society of Internal Medicine. He will talk about game-changing legacy with a novel perspective in diabetes management. So let's welcome Professor Aziz Rehman.
Professor Javed Akram, Professor Jabbar, PES organizers, and the audience. I'm really excited to give a short presentation in such a good gathering on a weekend. And there's some new development in the field of diabetes, and I think the life of patients as well as life of physicians will become easier. So the topic is game-changing legacy with novel perspective in diabetes management. My disclosures, I'm presenting for guests and will probably receive some honorarium, but the contents are entirely my own. And I have no other financial interest with the Getz company or any of its products. The management of diabetes starts with its diagnosis. There are first 3 steps which we take. This is according to ADA and EASD. First thing, of course, is the establishing the diagnosis. Very simple criteria: fasting glucose of more than 126 or HbA1c of more than 6.5% makes you diabetic. And then immediately we start a certain lifestyle. We cut down on calories and carbohydrates, and we ask the patient to get down his weight. And that is the first step. But most patients actually, they require medication. Before 2010, we used to try lifestyle changes for 3 months and see if that worked. But then we learned that in the majority, lifestyle changes alone, they do not work. Metformin being a very, very safe drug, cheap drug, so it is almost always started at the time of diagnosis. This is the current recommendation. So it is incredibly cheap and incredibly effective and incredibly safe. And I'm very, very sure about every single word I use here. Drug of choice, unless contraindicated because of some kidney problem or is intolerated. Started with low dose, typically 500 milligram twice a day, and escalated to 2,000 or 3,000 milligram. But many patients, they have some side effects, a variable, about 25% people, they develop some degree of gastric upset. It could be dyspepsia, bloating, constipation, or diarrhea, but only in 25% of patients. And it has to be administered twice or sometimes thrice. These are the 2 shortcomings of this drug. But luckily, with the preparation of XR, we have to use it only once. The new technologies, XR has got many technologies. The best technology will give you the chance of giving it just once a day. And luckily, because the drug is released slowly, your stomach is not exposed to the whole administered drug. So gastric side effects are reduced by 50%. So XR preparations are preferred over the regular preparations. So on the basis of these few comments, I draw a conclusion. And the conclusion number 1 is that metformin maintained its first position in the ADA and EASD guidelines, despite the availability of many other agents, which are contended to become the first line. Because it is safe, it is cheap, because it has got weight benefits, it can help to reduce weight, very, very low risk of hypos, and CV safety at least, but some CV benefits also, as shown by UKPDS. So if somebody is not on goal with maximum tolerated or maximum dose of metformin, what is the next step? After metformin, we could consider GLP-1 receptor agonists or SGLT2 inhibitors in some specific group, those patients who have high risk of atherosclerotic cardiovascular disease or have incipient nephropathy or have some heart failure, diastolic dysfunction, they go to this group. Those who are non-affording, where they cannot afford better medicine, most of them, they are treated with sulfonylureas. Sulfonylureas are effective glucose-lowering therapies, but beyond that, they do not have any benefits. EZDs, they have some downside, like they cannot be used in heart failure, weight gain, and edema. And the third one is DPP-4 inhibitors. I think after metformin, DPP-4 inhibitor is the best agent to consider. Why? Because metformin is this DPP-4 inhibitors are very well tolerated. The side effect profile of DPP-4 inhibitors is just like placebo. Patient hardly gets to know that he or she is taking some medication. Though it has got a modest HbA1c lowering factor, it is not as potent as sulfonylureas or metformin, but it is moderately effective. And glucose-dependent effect on insulin secretion and glucagon inhibition. Through GLP, through raising GLP level, it increases insulin level just the right amount, and it suppresses glucagon level just to the right amount so that your glucose level is brought to the normal level, it is not low too much. And very low risk of hypoglycemia. And the problem is, most of the DPP-4 inhibitors are renally excreted. And many patients with type 2 diabetes, they have some degree of kidney disease. So, and their GFR may be reduced. So we have to make some adjustment, and maybe we may not be able to make correct adjustment. So people with CKD would have problem with DPP-4 inhibitors. But the good news is, the linagliptin is one DPP-4 inhibitor which is almost entirely excreted through the liver, through the biliary passages. So irrespective of kidney function, irrespective of GFR, same dose of linagliptin, 5 milligram for everyone, that is safe. So I think you don't have to worry about the underlying kidney disease. Linagliptin is safe. There is a wealth of data in favor of linagliptin. There is Carmelina, this trials, cardiovascular trial, outcome trials, then Carolina trial comparing it with glimepiride, and trial in people with albuminuria, and trial in people with non-alcoholic fatty liver disease. These are conditions that often coexist with diabetes and people with heart failure and people who are elderly. So in all these populations, linagliptin has been found to be effective and safe option. So on the basis of this observation, we draw conclusion number 2. Linagliptin is a safe option in a wide range of patients with type 2 diabetes, not controlled with metformin alone, because of its atherosclerotic cardiovascular heart failure benefits, CKD benefits, non-alcoholic fatty liver disease benefits, and it is safe in elderly also. So we move on. How about combining these two drugs, metformin and linagliptin, because they have complementary action? Metformin reduces hepatic glucose production, which is abnormally increased in people with type 2 diabetes, and it also increases peripheral glucose utilization. Both of them, they lead to, they work on fasting hyperglycemia. Whereas linagliptin, by raising GLP level, by raising appropriate insulin level, by reducing glucagon level, it works on postprandial hyperglycemia. So if you can control both fasting hyperglycemia and postprandial hyperglycemia with complementary mechanism of action, with low risk of hypoglycemia, with no weight gain, so what else do you want? I think this looks like an ideal couple made in the heavens. Linagliptin and metformin would make a very good combination, very well tolerated, very effective, very safe on both fasting as well as on postprandial hyperglycemia. So based on this concept, metformin is available in combination with almost all DPP-4 inhibitors in various doses. So what if somebody is still not at goal? Then we have to consider another agent, and another agent I think out of these three would, in my opinion, should be an SGLT2 inhibitor because of its unique benefits. You know how it works? It blocks SGLT2, which is responsible for reabsorption of glucose. So it leads to glycosuria and leads to improvement in glucose level, and it also helps to lose weight, very modest BP lowering effect also, low potential of hypoglycemia, and many good effect on cardiovascular health, on heart failure, on CKD and atherosclerotic cardiovascular disease through its pleiotropic effects. So it is another great option. Many trials and these SGLT2 inhibitors, they have a unique mechanism of action. That mechanism of action is not shared with any other agent, irrespective of beta or alpha cells. You know, in type 2 diabetes, gradually your beta cells are lost. So all those drugs which work through beta cells, their effect tends to lose with time, but not SGLT2 inhibitors because the effect is over and above the effect of DPP-4 inhibitors. Then it is also independent of liver. You know, glucophage, metformin works through the liver, and when SGLT2 is added, it has got action over and affects metformin. So I think making a combination is very, very sensible. There is a wealth of data favoring empagliflozin. Just quickly going through EMPIRE outcome trial, I'm sure you are all familiar. This was a blockbuster trial, cardiovascular outcome trial, which proved that empagliflozin is not only safe, but is actually better than placebo to prevent atherosclerotic cardiovascular disease. EMPA-Kidney proves that it is renoprotective. EMPRE-REDUCE showed that in people with heart failure with reduced ejection fraction, it is very helpful. And very lately, we have also seen that EMPEROR-Preserved showed that empagliflozin is effective in people with heart failure with preserved ejection fraction also. We had few medicine for this category. And EMPA-HEART and EASE is in type 1 diabetes in addition to insulin. So based on these, we can draw another conclusion, and that conclusion is that empagliflozin is very attractive option for people with type 2 diabetes, particularly with the high risk of atherosclerotic cardiovascular disease, heart failure, and CKD, and those who are not at goal. Due to proven effect on heart failure with a reduced ejection fraction, heart failure with preserved ejection fraction, CKD, progression, and atherosclerotic cardiovascular disease. So how about combining metformin with empagliflozin? Earlier we examined combination of metformin with DPP-4 inhibitors. Now we are examining metformin with empagliflozin. Metformin reduces hepatic glucose production and promotes peripheral glucose utilization, whereas empagliflozin promotes glucose excretion. So they again have complementary mechanism of action and low risk of hypoglycemia and weight benefits. Again, another ideal combination. So based on this principle, many fixed dose combination of metformin with dapagliflozin, empagliflozin, and artigliflozin are available. So if still not at goal, you know, diabetes is a dynamic disease. Even if patient is very careful in medication and diet and weight management, typically diabetes requires more and more medication. So if two drug combo is also not enough to bring the glucose on goal, metformin DPP-4 combination has been tried, SGLT2 and metformin combination has been tried. How about a step further, combining all three together, since they have different mechanism of action? So let's see if we can combine them together and make into one pill. Rationale of triple combination therapy, complementary mechanism of action. All three drugs have different mechanism of action, enhance glycemic control, cardiorenal protection and weight loss, and low potential of hypoglycemia and weight loss. So all these things I think are very, very compelling reason to combine all three drugs into one. So let's see if we can see the data favoring metformin, linagliptin, and empagliflozin. These are the trials which have studied these three drugs taken separately. And they have seen that they are very, very beneficial. But bioequivalence studies have been done, and that has confirmed that if we add all three agents into one pill, they do not disturb each other's pharmacokinetics or pharmacodynamics or their effects. It is as if you are taking three pills, but actually you're taking just one pill. So I think that is a reason to draw the fourth conclusion. A three-drug combo of metformin, linagliptin, and empagliflozin is a very, very rational option for those who are not controlled with any two-drug combinations. Complementary mechanism of action, weight benefit, low risk of hypos, and CV rationale, CV and renal benefits. So the problem is that one does not fit all because they have given us 4 different preparations. I'm sure one would be right for your patient. So power of triple combo with complementary mechanism of action, good glucose lowering effect, good HbA1c lowering effect, weight lowering, and cardiorenal benefits with one pill. So a trio can actually do wonders. What are the pros of combining 3 drugs in one? Convenience, better compliance, better glycemic control, and better outcomes. There are some cons also. If we are giving 3 drugs in one pill, there may be less flexibility in individual drug dosing. But we have 4 different preparations, so I think one will be right for your patient. And then how to determine which drug is causing which side effect. I think life is easy, at least in this case, but all the 3 drugs in this combo pill has unique side effects. Linagliptin is without side effect, metformin basically GAT side effect, and empagliflozin basically polyuria. So I think we can determine which side effect is caused with which drug, so we can make appropriate adjustment. So what is the place of 3-drug combo pill in real world? It can be certainly used as a third line when 2-drug component is not working. It can be used as second-line drug also, and in my thinking, it can certainly be used in some selected cases as a first line also. Imagine somebody presenting with A1C of 10 with albuminuria, with diastolic dysfunction, is hypertensive. I think I would definitely clearly consider this triple even as a starting point. Because ADAE, as he says, that empagliflozin, you should not wait for metformin to fail. Even when you have taken metformin, without waiting for the metformin to go to the maximum, you could add empagliflozin. So 3-drug, if the A1C is still above 7, the next step is adding basal insulin. And the basal insulin, unless specified otherwise, means glargine. Because glargine is the commonest basal insulin, and this is the recommendation of ADA and EASD, that the basal insulin should be the next step. Why? Because the most widely used basal insulin is glargine, and we are very, very comfortable, experienced, but oral anti-diabetic agents must be continued. This triple combo must be continued because this basal insulin does not address postprandial glucose. And inject any time of the day, irrespective of the meal. It could be injected in the morning, in the afternoon, or at night. I typically advise it at night. Monitor fasting plasma glucose and adjust the dose to bring it to below 120. So very easy. You ask the patient to check the sugar every day. Irrespective of the time the insulin is injected, fasting sugar is tested, and average of 3 days is taken. If it is above 120, patient is asked to increase basal insulin by 3 units. So that should bring down the A1C to ADA and EASD recommended goal of less than 7. So to draw conclusion, the three take-home messages. One is a three-drug combo of metformin, linagliptin, and empagliflozin is a good option as third line, as second line, and also as first line therapy for type 2 diabetes patient. And the second message is add insulin glargine if not at goal with the full dose of three-drug combo. And the message number 3 is move on. Type 2 diabetes is a dynamic disease, even with three-drug combo and basal insulin. Some would require more intensive insulin regimens. I think we have to chase diabetes till we win it. So with that, I conclude, and this is my YouTube channel called Maderstand, and I make a lot of lectures. I think all topics in internal medicine are covered in this channel. You can scan this if you are interested, or you can just type Maderstand anywhere on the internet. You will be right on the channel. Thank you very much.
Thank you, sir, for your wonderful presentation. We'll take comments from our worthy chairs. First from Professor Abdul Jabbar.
I think the presentation was so simplified and the slides were so clear that I don't have any particular comment. I would fully agree with Professor Aziz Rehman, and as I say, most of our patients, when they come to us, they don't come with an A1C of 7.2. They come with an A1C of 9.2 and 8.2. So I always say, डॉक्टर को पता होता है अगली विजिट पे क्या रिजल्ट आएगा. तो इफ़ यू नो कि अगली विजिट पे 7.5 नहीं आ रहा, तो why to go for step? Start it early on and quickly. And the second thing which he suggested, that when the first, second and third line agents you have already used and your glycemia control is still not good, why to wait? You've got a simplified basal insulin available. We should use it, titrate it. जो मैं हमेशा कहता हूँ कि A1C जितनी जल्दी कंट्रोल होगा, कॉम्प्लिकेशंस इतनी कम होंगी. तो उसमें अगर देर होती है तो सवाल ये होता है कि ये देर डॉक्टर ने की थी या पेशेंट ने की थी. अब आप खुद सोच लें इसका सही जवाब क्या है. थैंक यू.
Professor Javed Akram, will you please share your comments as well?
Assalamu alaikum and good afternoon. I think it's always a pleasure listening to Professor Aziz Rahman. He makes things very simple. He always claims that simplicity is in his genes, and he has lived up to the reputation. I think just for, I think there are many colleagues from the family medicine here and also trainee doctors. This is not a drug for newly diagnosed diabetics, the combo therapy. Obviously, you will start with one drug and then, as he very elegantly step up approach. And once somebody is taking all three in different formulations, then it can conveniently be combined in one pill. The only thing that I know, I think in Pakistan now, probably 36 companies have got a registration of this combination of Lina, metformin, and an SGLT2. It's good. The competition is always good because the ultimate beneficiary is the patient, and the more the choice, the better the price for the patient, and better opportunity for us to work with the pharmaceutical industry. My point is that the idea of bringing in this polypill is to decrease the pill burden. But as a practicing physician, I'm using this a lot. But my point is that we should not be dogmatic about it and carried away by the pharmaceutical like marketing, that this is Amrit Dara or something, because if normally people give this drug in the morning, my point is Professor Aziz Rahman very again very nicely highlighted the advantages of metformin, and he emphasized that peripheral glucose utilization, but main action is on the liver, and main action is to inhibit gluconeogenesis by the liver. That means inhibit the glycogen breakdown. And that is why when patients are fasting at night, it addresses the fasting hyperglycemia. So if I am giving it at 8 a.m. in the morning with breakfast, one polypill, I'll still need to give metformin at night, maybe free dose metformin, because even with the extended release, the half-life of metformin has been extended from 4 hours to 6.2 hours. So at night, he will have no metformin cover. Actually, I am just planning a study of which Professor Aziz is a part of that study, where we are calling it a melody study. It's a switch study that from people who are, whatever they are taking, we switch them to this combination. And there, as an investigator, as an ethical dilemma, I am insisting that we will still give metformin at night. Fine, it's a good marketing point, but the first and the foremost is the patient, that early morning fasting hyperglycemia must be addressed, because that has its problems. So that is why other argument is, why not give it at night? And usually we avoid giving SGLT2 at night because people might need to get up again and again for polyuria or for passing the urine. So that is still a dilemma. Till dilemma is settled, that we have a super extended release metformin which will give a cover for more than 6.2 hours. We'll rely on having a single metformin pill at night. So that was the only thing that was I wanted to add. Otherwise, I'm very grateful to the organizers for the opportunity, and very grateful for the guests for arranging this very great lecture, a landmark talk during the PES conference. Thank you so much.
Thank you, our chairpersons, for the comments. Again, due to time shortage, we are not taking any questions. With this, we conclude this session. After the prayer and lunch break, we'll gather again in this hall for the launch of the SMILE project by Dr. Abbas Raza. Please be in time sharp at 2:30 p.m. Thank you so much. Have a wonderful day.